Hello, I'm Dr. John Leonard, and on behalf of CME Outfitters, I would like to welcome you to today's educational activity entitled Targeting Treatment, Selecting Optimal Therapy for Vulnerable Patients. Today's program is supported by an educational grant from Genentech Incorporated. Today's activity is brought to you by CME Outfitters, an award-winning, jointly accredited provider of continuing education for clinicians worldwide. Again, I'm Dr. John Leonard from Weill Cornell Medicine and New York Presbyterian Hospital in New York. And I'm really happy to be joined today by Dr. Cami Maddox from The Ohio State University, who is really an expert in lymphoma and many aspects of lymphoma research. Cami, thanks for joining us.
Thanks, Dr. Leonard. It's a pleasure to be here with you.
The learning objective for today's activities is to evaluate therapy options to select the most optimal treatment for older patients with relapsed and refractory follicular lymphoma. So before we get into our discussion, let's ask the audience a polling question. Which of the following factors is least informative when assessing the suitability of older patients with follicular lymphoma for treatment? Cognitive function, psychological state, presence of comorbidities, chronologic age at time of diagnosis, or I'm not sure. So in a moment, we'll get into this a case where we'll talk about some of these issues. But Dr. Maddox, what do you advise the audience? Which of these polling options are least informative as we look at a patient?
So really the patient's chronological age at diagnosis is the least important. It's really the other things that go into how their daily functioning is that really help you predict how they're going to do with treatment.
So that's a very helpful thing. I think over the years, people have come to appreciate the fact that chronologic age is not the main parameter or the only parameter, but that some of the other issues that we assess with patients, and that's going to be a big function or a big topic for the rest of our discussion. So let's jump into a case which I think highlights some of these issues, and maybe we'll get into a little bit about how you think about this when you see patients in your clinic. We'll move to a case, Mary. She is a 73-year-old female with advanced stage follicular lymphoma. She presents with 3 centimeter right cervical adenopathy, 3.5 centimeter right axillary adenopathy, 4 centimeter inguinal lymph node. She has a hemoglobin of 9.5, normal white count, slightly low platelets at 120,000. She has other medical conditions, including hypertension, hyperlipidemia, coronary artery disease with an EF of 50%, diabetes for 15 years, but some associated neuropathy and renal insufficiency. Despite these issues, she lives independently. And she's treated with 4 weekly rituximab treatments. It seems to work pretty well. And then 3 years later, presents with fatigue and new symptomatic cervical and axillary adenopathy. So Cami, how do you think about somebody like this? Let's talk first about at her initial presentation, how you might have thought about this patient, and then later during at the time of relapse. And maybe just give us a sense of your kind of general clinical approach, and then we'll get into some of the more formal assessments we can do.
Yeah, so we know that, first of all, when we look at Mary as a patient, that the incidence of lymphoma increases with age, and the median age at diagnosis in follicular lymphoma is in the mid-60s. So, Mary's age is a typical representation of patients that you would see newly diagnosed with follicular lymphoma. We know that the majority of patients will have stage 2 to 4 disease. So Mary's presentation for stage is also typical of a standard, if there is a standard patient. I think, when we're thinking of follicular lymphoma, we know that this is not a curable lymphoma. It's treatable. You can get patients into a remission, but they're more than likely going to relapse at some point. So our really goals in the treatment in a patient like this are how do we improve any symptomatic disease and improve quality of life, hopefully leading to the longest treatment durations, but really balance improving quality of life with treatment toxicity. I think oftentimes, there are many options for frontline therapy, including single agent antibody therapy or antibody in combination with chemotherapy, which are also options for treatment at relapse. I think it's not uncommon, especially for a patient this age, to be treated with single agent antibody therapy when they first present, hoping to induce a response and maybe delay needing further therapy. Patients can respond well to single agent antibody therapy if they don't have really bulky disease, which in Mary's case, she didn't. It can help improve symptoms, and the toxicity can be not as great as that in combination with chemotherapy. I would say that, some people like to wait and just defer therapy until patients have would require chemoimmunotherapy and maybe give less single agent immunotherapy at diagnosis. But I think in an older patient population, this is frequently used as an initial approach.
Do you find that for many patients in this age group that the number of clinic visits or the frequency of clinic visits is a big issue for them? I mean, it seems like, this patient might be able to travel on her own to clinic, or she might need, a family member to take time off of work, or she might be responsible for someone else, her spouse or significant other, that she doesn't want to come in because she's at home as a caregiver. How do you, navigate those issues in a general sense?
Yeah, I think, social determinants can be huge in deciding treatment. I mean, you're right. So one, does she have to, a lot of older patients don't want to burden other people. So if she's not able to get here on her own and she has to rely on somebody, even if she physically is able to get in, people don't feel comfortable doing that. If they're in less improved physical condition and have difficulty getting in, it can be harder to come, especially to a large treatment center like where we're at, where there's difficulties in parking and just getting to the clinic itself. When patients like this have a spouse or that they provide care for at home, they can be hesitant to leave them and not want to come as frequently. So I think administration of whatever therapy you're providing is important to the patient.
I think these patients, every patient with follicular lymphoma has kind of preconceived notions of chemotherapy or treatment in general. And I think that's one of the better things about follicular lymphoma is you have lots of options, and a lot of it is just spending your time with the patient, going through those and orienting them to what the options are, and whether or not their preconceived notions of how tolerable it's going to be are accurate in helping them make a decision.
I think that's so true. And I mean, we know that all the treatments have toxicity, some less more than others, but sometimes it's what toxicity, if it happens, is going to work best with their life and their comorbidities, what to them is an acceptable toxicity for their quality of life and what isn't.
So we'll get into more of these details. And I think, one of the things I'm excited to hear your take on is how you approach specific regimens in this type of population. But first, let's move to this concept of geriatric assessment. We've all seen the literature on this. Maybe some of us use them regularly, these assessments, some don't. But how do you think about these? And I'm sure some in the audience say this is a really great tool, and others are saying to themselves, I don't have time for this. I'm too busy. It's too complicated. I'd have to pull out a card, and figure it out and so on. So why don't you walk us through some of the options here and how they work, and then why they're valuable and how you apply them to your practice.
So geriatric assessments are now recommended by a lot of the different hematological and oncology organizations in patients who are over 65 years of age, because they can be both predictive and prognostic. But you are right that for many patients, this can be time consuming and require a lot. And so there are different screening tools. There are more broad ones in hematology or oncology, some specific to, say, aggressive lymphoma, that physicians can use to identify patients who might benefit from a full geriatric assessment. So sometimes some of these tools can be used that just define their physical function or their comorbidities to help you decide if they would benefit from a full assessment. A lot of times we think about patients in 3 different categories. So we think of patients as either fit, unfit, or frail. And patients who are described as fit, we consider they're candidates for intensive therapy. So we would treat them just, like a patient regardless of age or other issues. Unfit are patients who are candidates for treatment, but they're candidates for a modified general therapy or less intensive therapies. And then frail patients are patients who are considered for a more palliative approach. Very much less intensive, or maybe just palliative type treatments. So there are actually a number of different factors that go into a multidimensional geriatric assessment, looking at a patient's physical function. So how do they get along? How do they get around? This can be looked at by a number of different tests, such as walking speed, strength testing, performance status. Looking at patient comorbidity, so what other underlying medical conditions do they take and are they treated for? Something that we mentioned a little bit earlier, socioeconomic or their social support. So what sort of support do they have at home? How are they going to get to appointments? And then also financial challenges. Psychological state or cognitive function, so dementia, which can be very mild, but can definitely have an effect on treatment outcomes. Along with looking at depression, isolation can be an issue in elderly patients. Polypharmacy is huge, and I think that can apply in this situation when we're talking about the different types of oral therapies, because patients who are on a number of different therapies, oral sounds great because they don't have to come in for treatments, but then you're looking at adding, yet another pill to maybe their already large pill box. And then nutrition. So we know that patients who have low BMI, indicative of poor nutritional status, actually have worse outcomes with treatments. When you're looking at interventions in these, so there's a multidisciplinary approach to these. So including in a practice with lymphoma, we have a care clinic actually, which is a cancer and aging resiliency clinic. And that consists of a multidisciplinary team that includes hematology, pharmacy, physical therapist, the audiologist, the dietitian, case manager, and then cognitive assessment and a research coordinator. And all these multidisciplinary teams assess the patients for these different parameters, and then they're able to identify areas that the patient would benefit from assistance or help, and where intervention might be able to decrease the risks of treatment.
That's a great resource. I think that that I think many centers have some version of that, although some people don't. And so I guess probably the advice, if you don't have that type of resource available, is at least to provide some attention to these areas and perhaps make a referral if you need to, if it bubbles up through your assessment that, hearing is an issue or diet is an issue, make sure that the patient sees that person, even if the team isn't automatically reviewing every patient.
I absolutely agree. And even with this resource, I, don't necessarily refer every patient in this age category to that clinic. But I think considering these things in your, initial assessment of the patient and when you're deciding treatment can be very beneficial. And then making specific referrals to things that you notice are very clearly in need. If the patient has clear poor nutrition, if they seem to have hearing issues, referral to audiology for an evaluation. Or just looking at each of these individually and making sure if there's a blaringly obvious thing that you're addressing it, because again, it is predictive of outcomes with treatment.
I think one other resource that's often helpful for some patients is palliative care. And I think we're getting much more attuned to that in the hematologic malignancies. I think our solid tumor colleagues are much more, routinely used to contacting palliative care, given the nature of many of their patients. And, we in heme malignancies have had so many active drugs, and particularly in lymphoma, you can keep going and going in many cases. And palliative care can be very helpful, even if the patient is in a curative situation, to help not only pick up on some of the issues that we don't see, but provide another layer of support for the patient.
Yeah, I think another area that I found very helpful is the physical therapist, even in patients who you may not identify as higher risk to begin with. If you're going to give them treatment, a lot of times patients will lose, muscle mass and nutrition throughout treatment. And I found that can be very helpful if they get PT during treatment or are taught exercises to do during treatment. It can improve their recovery after treatment.
So let's go to another polling question, and this question focuses on patients over the age of 80. This, maybe some days ago would be considered the super older patients. The older I get, the younger 80 seems. But in some ways, 80 is the new 60, if I've got that right, or maybe, I think I got that right. But what is the primary goal of treatments in patients over the age of 80? Is it to cure their disease, the caretaker's wishes, quality of life, disease bulk decrease, or I'm not sure. And again, we're focusing primarily on follicular lymphoma here. Cami, how do you approach this? And I think we have a nice figure that gives us some of the aspects of goals of treatment to think about, particularly in this patient population.
Yeah, so in this patient population, and really in follicular lymphoma in general, we know that we're not going to cure the majority of patients. This is not thought to be a curable disease. So we really want to maintain their quality of life. So what I think about when if somebody, first of all, do they need treatment? And then what are my goals of treatment? If my goals are to improve their quality of life, what symptoms are they having? What am I going to improve by treating them? Their symptoms, their cytopenias. How am I going to do that? By minimizing toxicity. So I don't want to treat their symptoms, but give them 3 more problems, because then I really haven't helped out. So what's best to treat their symptoms, improve their quality of life from their symptoms, but not give them more problems. And then I think you also think a little bit about delaying the need for further anti-lymphoma therapy. So is this somebody that maybe you can get a long time out of single agent rituximab and they're not going to need more aggressive therapy? Or is this somebody that probably really, qualifies for and would benefit for a combination approach up front, because it's likely to give them a longer remission duration, and then maybe they won't need another therapy, or it'll be, a long time before they need something more.
So before we get into some of the specific treatments that we use commonly in follicular lymphoma, let's just talk about some of the common chemotherapy and frankly, other drug-related toxicities that we see and need to think about specifically in this older patient population. What bubbles up that commonly fits into your decision-making as you make choices?
So when we're thinking about treating this population, we want to think about how not to exacerbate or worsen their underlying, what can be considered as geriatric syndromes or other underlying comorbidities. And you're right, this doesn't just apply to chemotherapy. As I mentioned, many of the oral or the targeted therapies have side effects that can be similar to chemotherapy, maybe just different severity. So we talked about functional status being very important in this patient population. So we know that some treatments will cause neuropathy, and that can worsen functional status, increase patients' risk of falls, broken bones. Any kind of GI toxicity. So, I've listed here diarrhea, but nausea, vomiting, any of that. So diarrhea can worsen incontinence, which can worsen pressure ulcers, but really any kind of GI toxicity like nausea, vomiting, diarrhea is going to decrease functional status because patients are not going to be as active. It's going to decrease nutritional status, which we know leads to worse outcomes, put patients at risk for dehydration, which we also know can be problematic. Some therapies, are associated with cognitive impairment, so-called the chemo brain, and this can really exacerbate an underlying dementia in patients and lead to worse outcomes. And then hematologic toxicities. So anemia can be a huge one that has actually been shown to correlate with worsened outcomes. So just with increased risk of infection with neutropenia, increase with their bleeding, especially with falls with thrombocytopenia. So these are some of the more common toxicities with chemotherapy, but with some of the targeted therapies that can exacerbate underlying problems that these patients have.
So let's get into some specific treatments that are commonly used in follicular lymphoma. And we referenced for our case earlier the idea of using rituximab or an anti-CD20 as a single agent is potentially a good choice for an older patient. How do you think of that in the course of follicular lymphoma? Are there any scenarios where you might not use that or where you would be worried about that?
I think that this can be a good choice. If you give just 4 weekly doses, patients can come in 4 times a week. I don't give maintenance. If I do that, there can be increased risk of infection. I would say that I tend, in the COVID pandemic, this has been a concern because we know that patients, especially those who haven't been vaccinated prior to this, can have increased complications of COVID. And so I would say you really don't want to use this if patients don't need treatment, which I think oftentimes can happen where patients have a diagnosis, they maybe don't meet a lot of criteria for treatment, but they receive this CD20 antibody to try to prevent them from needing something further, even though maybe they don't have symptoms that you're trying to improve. So really looking at, am I giving this because it's going to make something better? Are they anemic and that's going to make their anemia better?
So a large percentage of patients, as the audience knows, ends up getting chemoimmunotherapy. Usually with an anti-CD20 antibody with either bendamustine or sometimes CHOP or CVP. How do you think of that in the older patient population?
These are all potential options. I think the way I think about these three, so we know that in the randomized studies that there was an increased risk of death in patients greater than 70 in the bendamustine immunotherapy arms. So I think that ways that can be used to address this can be a decrease in the dose of bendamustine. So instead of giving the 90 milligrams per meter squared, you could consider giving 70 milligrams per meter squared, giving a short number of cycles. So again, our goal is to improve quality of life. So if you can give 3 cycles and get the patient into a remission, maybe you don't need the other 3 cycles. Thinking about growth factor support and antibiotic prophylaxis, because a lot of these were increased risk of infections. A lot of the deaths that occurred. So how can you do infection prevention? And then, a lot of the deaths occurred in the maintenance arm. I don't typically give maintenance in follicular lymphoma in general, but I would say you really have to think about if you're going to approach an elderly patient after you've given them chemoimmunotherapy and give them more treatment with maintenance, what's really your goal of that?
Yeah, I would agree. I think this observation in the gallium study, with bendamustine is intriguing, but certainly hard to know how definitive that is in changing practice. And I agree with your point as far as the maintenance. I think it's probably less of an issue if you're not routinely giving maintenance, and we tend to share your view on that.
I mean, and it's not like, we know that our CHOP chemotherapy had more toxicities than bendamustine. I think, when you're thinking about using this in an elderly population, you want to think about cardiac function. Sometimes people will choose CVP, even though the progression-free survival is less than that of with the others. If there's a contraindication from the standpoint of cardiac function, that might be an option in elderly patients. Dose reductions, and again, thinking about growth factor support and antibiotic prophylaxis or other things that I really think about when I'm using chemoimmunotherapy. But again, these are regimens that cause neuropathy. So you want to go back up to thinking about how that can increase risk of falls and worsen patients' functional status. If you're in patients who have maybe more aggressive follicular lymphoma, you can consider pre-phase with steroids, which has been shown in diffuse large B-cell lymphoma to help with toxicity. So just different alterations to dosing, and then really growth factor and infection prophylaxis, I think, are huge when you're thinking about these chemotherapies.
So finally, there are several newer agents that I think are important to touch on before we wrap up. The issues of lenalidomide, PI3 kinase inhibitors, EZH2 inhibitors. How do you think about those in older patients? These are mostly used in the relapse setting, but are they particularly good or concerning choices in older patients?
I think these definitely have risks and benefits. So there are oral therapies, so the patient doesn't have to come in for infusion. But as we talked about, polypharmacy is a risk in the elderly. And so any of these oral therapies add yet another oral therapy for the patient to take, and to make sure they're getting them on schedule and not mixing them up with other medications. In addition, agents like or lenalidomide also require some sort of DVT prophylaxis, so aspirin or anticoagulation, depending on the patient's history. And so that's another oral medication that the patient has to take in addition to the treatment medication. I think, again, just thinking about the toxicities that each of these cause. So these still can cause cytopenias like chemotherapy. We know that the PI3 kinase tend to cause a little bit higher infection, diarrhea. We know that copanlisib is an IV one that can be associated with some hypertension and hyperglycemia. So what are the patient's underlying comorbidities? And then what are the toxicities of these treatments? And is it something that's going to exacerbate an underlying problem for that patient? Then it might not be the best choice.
And then finally, the issues of some special scenarios that we deal with, generally unfortunate or challenging transformation, early relapse, COVID-19 issues. How do you briefly think about those in this patient population?
In transformation, I think just similar to what you would do in de novo diffuse large B-cell lymphoma. I mean, do you think that you can cure the aggressive component with chemotherapy? And then thinking about, is this a patient a candidate for R-CHOP? Do they need mini R-CHOP? Should I use a pre-phase growth factor support? Early relapse, I think this is challenging. We know these patients have a lower overall survival than those patients who get a longer remission to treatment. So I think you really have to look at the patient and decide, is this somebody that, and of course we don't 100% know, but is this somebody who's at risk of dying of their follicular lymphoma, or do they have other comorbidities that probably put them at more risk? And if they're at more risk of dying of their follicular lymphoma, are they able to tolerate me being more aggressive, or what approach are they able to use here? And really go back to that, what are your goals of treatment? And then I think in the COVID-19 pandemic, we just have to think about largely about the use of CD20 antibodies, encourage patients to get vaccinated before we use these. I don't think the use of maintenance of these agents as maintenance in a non-curable setting is probably the best idea, personally.
Any summary points you'd like to make as we wrap up?
Yeah, I think, the older patient population is a common population in in lymphomas and follicular specifically, and older and frail patients really need this highly personalized assessment and treatment planning. There is comprehensive geriatric assessment, but there are ways to identify these patients with shorter, smaller assessments too. Identifying these factors that contribute to outcomes and trying to address or fix certain things can definitely help with their outcomes. And there are treatment options for patients who are unable to tolerate an aggressive approach.
Well, thanks very much, Dr. Maddox. I want to also just give our learners some SMART goals, which are smart, measurable, attainable, relevant, and timely. And these include utilizing geriatric assessments, engaging in a multidisciplinary approach to manage older patients, using shared decision-making when setting realistic treatment goals, and watching carefully for worsening comorbidities during treatment. I encourage everyone to watch the companion activities where I'm joined by another outstanding faculty member. The first is determining a patient's risk, identifying rapid progression of follicular lymphoma with Dr. Carla Casulo. And the second is evaluating the options, assessing emerging bispecific antibody treatments for follicular lymphoma with Dr. Elizabeth Budde. Also, please visit the CME Outfitters Oncology Hub to access additional activities on relevant oncology topics, including resources and patient education materials. Lastly, to receive CME or CE credit for today's program, please complete the post-test and evaluation. You'll be able to download and print your certificate immediately upon completion. And want to again thank Dr. Kimmy Maddox for a great discussion. And thank you, our audience, for joining us today.